Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Société Francophone de Nephrologie, Dialyse et Transplantation, and the Junge Deutsche Gesellschaft für Nephrologie, Marcus at Home welcomes Professor Grégoire Le Gal in Ottawa, Ontario, Canada, with whom we would love to discuss adjusted D-dimer cutoffs for diagnosing venous thromboembolism, VTE, focusing upon his ADJUST study, which has been published in JAMA in early 2026. Dear Grégoire, it's a pleasure to have you back at home after our 2023 discussion on your symptoms study.
Thank you. Thank you for having me.
Dr. Grégoire Le Gal is professor in the Division of Hematology of the Department of Medicine at the University of Ottawa and a senior scientist in the Ottawa Hospital Research Institute. His primary research interest is the diagnosis and management of venous thromboembolism, including the clinical diagnosis of VTE, focusing upon clinical decision rules for VTE. Professor Bauersachs is an angiologist and hemostasiologist at the CCB in Frankfurt and author of the Voyageur, Caravaggio, Einstein, Einstein Choice, and many other landmark studies. Welcome here by Marcus at Home. And please, Professor Le Gal, it's your turn.
Well, thank you for having me again and looking forward to the discussion with you all today. And happy to present the results of our ADJUST-DVT study. We presented this at the ISTH meeting in Washington last year. And as you said, it's a follow-up study almost to our ADJUST-PE study that was published like almost 10 years ago now. And obviously, as soon as we published that 10 years ago, the first question that came up was, hey, can we do that as well for DVT, for suspected DVT? And we're like, we don't know, maybe, likely yes, but it would remain to be demonstrated, right? And actually, interestingly enough, back then we looked at that and trying to see if there was some correlation studies about, D-dimer levels as compared with the thrombotic burdens of DVTs versus PEs, but couldn't find such data. So we thought, just to be safe, we should do a dedicated study. So here we are. So as a background, and most of you certainly know that already, the D-dimer levels tend to increase with age, and as that in turn decreases their specificity and usefulness when we particularly want them to be useful in elderly patients, because they are the ones who have more risk on being treated on anticoagulants while awaiting for diagnostic confirmation. They're the ones who are in more danger by prolonging their stay in hospital in the emergency department with the risk of confusion and all of that. They're the ones who we don't want to give a dye if we don't have to give dye to, and things like that. So overall, really maybe the main target of non-invasive diagnosis should be the elderly patient, yet at the same time, due to that physiological increase in D-dimer levels, we cannot use the full potential of the D-dimer test in that population. So what we really wanted to do was really very simply prospectively validating whether the age-adjusted D-dimer cutoff that has been already validated for PE, for suspected PE, was able also to decrease the need for leg imaging in patients presenting with suspected DVT. So we did set up a multi-center, multinational study. So 27 centers, 4 countries, Canada, and three countries in Europe, Belgium, France, and Switzerland, and recruited 3,200 patients. Took us a long time to do that. There was a certain pandemic in the meantime, as you know, that slowed us down as well. We tried to keep it very simple and very pragmatic in terms of inclusion criteria. So pretty much every patient coming in with a suspected leg DVT, so very important to say that was only leg DVT, didn't have any atypical site or even upper extremity were not enrolled. We enrolled patients age 18 or more. That was one of the questions that came up is, hey, you're only adjusting the D-dimer level based on age after 50, so why include patients age 18 to 50? Because we felt it was important enough to be able to provide the additional proportion of all comers with suspected DVT in whom the age-adjusted cutoff would be useful. So we decided to include everyone there, excluding those with PE symptoms, because that was already done. those who would have had more than 48 hours on anticoagulants, because as you know, as soon as you start anticoagulants, like it's a few days after, the D-dimer level starts to go down. We excluded ongoing pregnancy because that's a very different question and another reason for D-dimer to be elevated. And then for reasons of follow-up, patients with life expectancy less than 3 months that wouldn't be accessible for the follow-up. We did try to keep the diagnostic algorithm very simple as well, using what we've been using for many years now, which is starting with a pretest probability assessment in the ones who are deemed to be at high pretest or likely. And you will see that something to be discussed as well, maybe, is that in Europe, participating centers were mostly using a 3-level well score, so low, intermediate, or high, while in Canada, we are using more like the unlikely, likely scheme. So we decided to accommodate both and to accept the two ways of scoring the pretest probability. And in patients with a non-high or unlikely pretest would do the D-dimer, those with a D-dimer below 500 would have DVT excluded, but so would the ones with the D-dimers that would be greater than 500, but below the age-adjusted cutoff. While those with a positive age-adjusted D-dimer or with a high pretest would need to undergo ultrasound. Our primary outcome was the 3 months risk of recurrent VTE in patients in whom DVT would have been ruled out. We use an intention to diagnose analysis. And very important to say, if I go back to my slide, that the primary outcome was to be achieved here. So we wanted to have, and that's why we had to include 3,200 patients as well, is that we needed to have enough patients with a D-dimer greater than 500, but below the age-adjusted cutoff to be able to demonstrate that in that specific subgroup, we would be safe. That's often something that I criticize about diagnostic studies, is that it's a bit too easy we could have done like a merger, right, of these two subgroups and provide a combined, outcome within these two groups, but that would have diluted the result of interest, which is really the new intervention, which is really that D-dimer greater than 500 but below the age-adjusted, because then you add a lot of patients with a D-dimer below 500 in whom we already know for many, many years that it is safe to exclude. So that's something important, a strength of the study, I believe. In terms of secondary outcome, we wanted to look in particular at the subgroup of patients age 75 or more. And obviously, we wanted to see how much we would increase the yield of the D-dimer test by using the age-adjusted cutoff. So again, in terms of statistics, we wanted the 3 months risk of VTE to be no higher than 3%, which is an accepted standard for diagnostic outcome studies. And based on the proportion of patients who were aged more than 50 years, and based on the repartition of the D-dimer results in our previous PE studies, we came up with the number of 3,200 patients. These are the main characteristics of the included patient. I'll let you have a look at that. Pretty much, well, not much to comment on. Well, some people in the correspondence after the paper was published, you will see that published soon, were asking, oh, can you use it in patients with a previous VTE or in patients with active malignancy? We did have some patients with these risk factors, maybe not in big numbers, but in numbers that are pretty typical in diagnostic studies anyway. And as you can see, 2/3 of patients were classified as having a non-high or unlikely pretest, while 1/3 had a high or likely pretest probability. This is the main slide of the day, I guess. So again, 2/3, 1/3, among the 2,100 patients with a non-high or unlikely, 500 of them had a negative D-dimer below 500. So in those patients, well, something that I'm sure we will discuss later as well, despite having a negative D-dimer, a significant proportion of them did undergo an ultrasound, which fortunately was positive only once, but we looked at it and it was confirmed. It was really a true positive case for sure. The rest of it, like 14 were lost to follow up, 2 withdrew consent. Another 12 patients did receive anticoagulants because they were either found with a distal DVT or were diagnosed with AFib during their initial presentation as well, meaning that 503 patients did a 3-month follow-up of anticoagulants. Of them, one had an event during the 3-month follow-up. So if you add that one to the one who had a proximal DVT at initial workup, overall failure rate of the D-dimer below 500 in non-high pretest probability patient with a suspected DVT would be 0.4%, with an upper limit of the 95% confidence interval of 1.4. Now, our main subgroup of interest, which is the group of patients with a D-dimer greater than 500 but below the age-adjusted, that group comprised 161 patients, which represent 5% of the total sample size. That was a bit disappointing to us because in our PE study, they were representing more like 10% of the total sample size. So the additional yield isn't as big or as important as it was for the patient with suspected PE. The same, a lot of, actually more than half of these patients did get an ultrasound, despite the fact that the protocol was saying that, DVT was ruled out, you could not treat and follow. By chance, none of these were positive for a DVT. And during the 3-month follow-up, we didn't lose any patients there. None of them withdrew consent. 2 had AFib or other cardiac condition requiring anticoagulants. So at the end of the day, we had no failure in that subgroup, and with an upper limit of the 95% confidence interval of up to 2.3. So confirming the safety in that specific subgroup of interest. And then quickly, the other ones were among the ones with a positive D-dimer. Obviously, we had many more proximal DVTs there, but overall, once you had that D-dimer that ultrasound that was negative, the failure rate was pretty much similar to what you had in negative D-dimer patient, which was 0.4%. And in patient with a high pretest probability, same thing, like 28% of confirmed DVT, a few lost to follow-up, and 6 failures in that subgroup, leading to a 3-month risk of 0.6% upper limit to 1.4. So overall, prevalence of DVT 13.5% as well. Overall study failure rate 13 out of the 2,974 that were followed out of anticoagulant therapy. So a 3-month rate of 0.4%. So confirming that such a diagnostic strategy would be very safe to rule out DVT. And these are again the yield, right? So below 500 in the entire cohort, the 531 patients only represented 1/6. And again, that's much less than in suspected PE patients, where we typically say that 1/3 of suspected PE patients have a D-dimer below 500 with a non-high pretest. And when you change to the age-adjusted cutoff, you increase that by 5% in absolute value, a bit more if you focus on the group of the patient with a non-high or unlikely pretest. The subgroup of patients aged 75 or more, again, that was one of our main clinical questions. And here the increase is much more interesting. There were 5.5% of patients aged 75 years or more who had a D-dimer below 500. That proportion went up to 16.5% among, if you include all the ones with a D-dimer below the age-adjusted cutoff. And the increase was even more striking when you focused on the group of patients with a non-high pretest, where you had a 17% increase. So that's more significant to us and more interesting clinically for sure as well, because these are more patients that you can discharge from the emergency department without them having to wait for an ultrasound or without them having to receive anticoagulant therapy. So overall, I would say age-adjusted safely rule out DVT in unlikely non-high pretest priority patient. This is an increase in the yield of the test as compared with the 500 D-dimer cutoff. In terms of strength, large study, I guess one of the largest in terms of patient with query DVT. I think again that ability to detect the 3-month risk, particularly in that subgroup of patients, was one of the strengths of the study. A strength which is also a limit is that we allowed any highly sensitive D-dimer assays that people would be using at their centers during the course of the study. So people see it as hey, did you have enough patients with my specific D-dimer assay to confirm that my specific D-dimer assay is safe? Short answer is no, because in that subgroup, then we don't have enough patients to conclude. But I think in perspective, you also have to add that to the body of evidence that we have about query PE and all the retrospective studies that were done around the topic. So I don't have, there are some papers showing that maybe the proportion of patients with a negative D-dimer might vary a bit depending on the type of assays that you use, but I couldn't find any even retrospective studies suggesting a bad safety signal for one assay in particular. Certainly, this protocol deviation of having a significant number of patients having had an ultrasound despite the protocol saying that they didn't need one is a limitation as well. I can't deny that. Whether that reflects just physicians' behavior or maybe reluctance to change as compared with a regular algorithm, or because they had an alternative diagnosis that they wanted to explore and decided to order the D-dimer, the ultrasound despite the DVT being ruled out. Unfortunately, we did not capture that information. I think that's something that maybe future will tell, right? I would hope that, with time and with the integration of the age-adjusted D-dimer cutoff in practice for suspected DVT, that proportion of patients getting an ultrasound despite the negative D-dimer will go down. So that's it for the study in a nutshell, concluding that again the age-adjusted D-dimer does safely rule out DVT in patients with an unlikely or non-high pretest probability. And one of the beauty of the study is that it means also that now we can implement the age-adjusted D-dimer for both suspected DVT and suspected PE, not for the other location. I think that's important to remind people, right? That wouldn't apply to the cerebral vein sinus thrombosis or to a pro-extremity thrombosis. These are different clinical questions. Can't finish without thanking all the co-investigators, adjudicators, DSMB members, clinical research people, and patients, obviously, that were all involved in that study. And now I'm looking forward to the discussion.
Great. Thank you for your presentation from your study results. And please, Professor Bauersachs, maybe like you to share some thoughts.
Yes. First of all, Grégoire, really my compliments. It's an excellent study, which really has the power to change diagnostic pathways globally, really. And that's another strength, that it's performed in Canada and in Europe. And it's a large study. It's more than 3,000 patients. And even though you were disappointed that the group of interest was only 5%, it's still a substantial number. And you see the confidence intervals, and it is well below your target. So that's a big success. Also, there was zero loss to follow-up, because that's another issue. People would argue, if you lose 10 patients, perhaps they're all dead. No, no loss to follow-up in that group. So that's very important. And congratulations, this is really changing the diagnostic management. It's interesting that you mentioned that a lot of ultrasound was still performed, even though that was not in the algorithm. My question was there a difference between Europe and Canada?
Good question. I don't even know. But I will look. Yeah.
It's interesting, because we in Germany, we have present guidelines, German-speaking guidelines, and we have two algorithms. One is close to your algorithm, but the first algorithm really has the ultrasound in the first place without the D-dimer. And the reason for that is that the ultrasound is widely available in Germany. Every institution has that, and so everybody does the ultrasound, and there may be even financial issues if it's a private patient. So that's another interesting question, why it was performed in your study, even though it was not necessary. But having said that this is in the guideline, the first algorithm, and this is what is done in Germany, I have to say this is changing now, because in the emergency rooms, in the hospitals, in the private practices, we have less and less availability and resources for the ultrasound. And so that's why your study is now so important.
Yeah.
Absolutely.
And you're right. And in Canada, it's true that that's really an actual limitation, right? A lot of smaller hospitals, for example, would not have an ultrasound technician at night, right? So very often then they would give an injection of heparin or DOAC and say, okay, come back next day and we'll. So certainly that's an important, and when these resources are fading away everywhere, right? It's harder to access.
That's what I observe in Germany now, because the patient comes to the emergency room, doesn't have the highest priority, waits until midnight, and is being sent home. And
Yeah.
that's why for Germany or for the German-speaking countries, your study really comes at the right time. You also mentioned, that was interesting, I thought, that there was a difference in the frequency compared to the ADJUST-PE study. There was 33%. What is the reason for that? Do you have an explanation?
I don't know. Yeah, it's really bizarre because the prevalence in the study isn't so high, right? It's 13%. So you would think that the D-dimer and the patient's age, the average age was regular as well, right? 50, 59. It's not too high. So maybe indeed, like why would, or patients who come in with leg symptoms, maybe if they don't have a DVT, they might have cellulitis or something that also makes their D-dimer go up, and maybe that's why we have a lower proportion of negative D-dimer. I'm not sure actually. But it's interesting because remember what I was saying in the introduction that can we directly extrapolate PE data to DVT data, and it looks like we cannot, right? D-dimer don't really behave the same way.
Yeah, that's why it's important, I think, to have that large study. And that's why it was, published at JAMA. So that's really important, and it's very important for us. There's another thing which I like in your study, and you said it's a limitation, a strength, that's using two different well scores or two different classifications. In Germany, there's a wide use of likely and unlikely also in some centers. But can you comment any differences in the outcome between 2-level well score and 3-level? Perhaps explain it again. Not everybody is perhaps familiar.
Yes. I think historically the reasons why in Canada in particular they focused on that unlikely pretest is because they weren't using the highly sensitive D-dimer assays. Remember the Simply Read assay, which was like a qualitative assay, and sensitivity was less good.
It was a point of care test, not as sensitive. Yeah.
So they didn't want to use it in patients with low plus intermediate. They wanted to restrict to a lower risk category, right? So I think historically that's why they started to focus on the unlikely. I remember looking at whether, so certainly in terms of outcomes, things are good on both sides, right? There was no additional failures by including all the low plus intermediate. It works very well as well. You could argue, well, now that we know all that, why don't we change the cutoff between likely and unlikely to mimic the high versus non-high kind of thing, which I'm sure we could from a safety perspective. I looked at that in PE and in DVT data, and actually the yield, the gain is not that much, because what happened is that the higher your well score, the less likely the chance of finding a negative D-dimer as well, right?
Yeah, that's of course, yeah. And it would create new confusion. We are used to it for now a quarter of a century, and so I think it's good, and otherwise it would confuse people, and that's probably, and there's not a big gain anyway.
No,
as
exactly.
you said. Do you have, that's a technical question, would you be able to show the figure 3 of the publication? Because I think this is a very nice illustration of what we are talking about here. It really shows, and you could perhaps explain a little bit how to read this figure, because I think that's a very nice summary.
Thank you. That took me, actually, I'm not the best tech savvy person, so that took me some time to actually do.
It's worth it. It's worth it.
It was kind of trying to have a visual representation of the results, right?
Yeah, exactly.
So what we tried to build was, so this is patient's age here at the bottom, right? So the first, and here in the y-axis is a D-dimer test, the D-dimer level. So the 500 cutoff, the regular cutoff is here by that horizontal line, right? And as you can see, we had only 2 patients who had a DVT despite having a negative D-dimer. Remember that the one with I was showing you the low pre-test and the negative D-dimer, and the other one during follow-up. And that's why we actually call that the triangle, which is those patients who have a D-dimer that is greater than 500, but below the age adjusted. So after age 50, then instead of being horizontal, that line starts being diagonal, right? And going up to, 1,000 for age 100 kind of thing. And that's where you can see that we had these extra patients in whom none of them had a DVT. And you can see how actually, so the colored dots, like the orange dots, represent patients with confirmed DVT, and the open dots corresponds to patients with no DVT. And you can see how actually the orange dots do align just above that line, right? So, and we had the same for the in the suspected PE study. So it really looks like you have that correlation between physiological D-dimer level, and actually that's how we came up with the age-adjusted D-dimer in the first place, right? Like 15 years ago, looking at a bunch of PE suspected PE databases and doing some meta-regression, trying to figure what was the lowest level of D-dimer at which patient would have a confirmed PE. And that's how we came up that, for each year of age, that optimal D-dimer cutoff would increase by, actually it was 11. We chose to increase it by 10 just to make it easy to remember.
Yeah, I think that's why I can see it very nicely in this image here. All those patients in the triangle, all these green circles, they are all patients who did not need an ultrasound.
Yeah.
So that's a lot. That's
Yeah.
really a lot of those patients. So we're talking about, resources and problem with the resources, especially in the future upcoming. And so these patients can be safely sent home without the ultrasound. And that's very important now. They don't have to wait until 2 o'clock in the morning in the emergency room because they were safe. That's a very, very important message here.
Correct. And, we were thinking for now, I don't know how is it in Germany. In Canada, we don't have yet an approved point of care, highly sensitive quantitative D-dimer assay that we could use. But because another big thing with that is, for example, patients from retirement homes, right? Where it's really, really hard for them to have to come to the emergency department to wait several hours, as you said. Well, if we could have either at their family doctor's office or even at the retirement home directly a point of care D-dimer and a well score, we could truly spare them the visit to the
that would be really great if we had that. That's actually another strength, really, because you were using completely different sensitive D-dimer tests, and they all worked. So there was not an issue, and it's really a no-brainer to just take the age and calculate the age-adjusted limit. So that's really easy, and that's valid for all the D-dimer tests. So that's very nice, and it works. So that's very good. You didn't have a same, in the publication at least, the same figure for the PE, for ADJUST PE.
No, we did it after the fact, but you're right. We didn't have it in the paper. Yeah. That was a reason.
It's very nice because it says everything here. But perhaps Gunnar has some questions, or Carolin.
Yeah, thank you. I have maybe some more basic questions. So you said we see that the older people had a higher D-dimer level. So what's the mechanism behind that? Did we know that?
With age, you mean? Why do older people? We don't know, right? Whether it's, well, certainly some of it must be comorbidities, be it cancer, but it's a whole new concept of inflammaging, right? Where it looks like with age, a lot of comorbid inflammatory conditions arise that might in turn, Rupert might have more to say about that.
No, I would ask Carolin, because as a nephrologist, she perhaps knows if there's a role of the kidney for an increased D-dimer in age with impaired renal function.
Usually the CKD or dialysis patients have a lot of comorbidity, and they have a shunt or a fistula or something like that, and usually have microthrombism. somewhere in there, but that there's a really correlation or a cause of getting high dimer only because of kidney. Maybe Gunnar knows something else.
No, actually, lab values may be slightly elevated, but we would not go for specific inclusion or exclusion rules. So, Grégoire, did you include people down to dialysis? So, advanced CKD, or was there a cutoff at some place?
No cutoff. So they could have been included. I'm not sure we had many, but I remember looking in the past remember that in our PE studies, one of the challenges, because we use a CT scans and we ended excluding patients with a clearance below 30, right? I don't know if that was the right thing to do always, but anyway, that was done. But we looked at what you were saying, Carolin, right? Trying to see, and we couldn't really find like a good correlation between D-dimer and kidney function, or between the yield of the D-dimer, except the correlation was the one confused by age, right? But when you were trying to do independent to age, it didn't seem to have much there.
Yeah, but it's as you said, there is an activation of coagulation that increases with age, and you can see that with an increase of factor 8 or an increase in fibrinogen. You can even see that the APTT is shorter, lower in elderly patients, and the prothrombin time is shorter. So the Quick-Wert is higher. And so that also is an indication of coagulation activation, and that's normal. I mean, factor 8 is just increasing with age. And so for me, it's not a big surprise that D-dimers are going up with age.
I have another question. The patients who were tested in the study came to the emergency department, sent by a family doctor or somebody else. So what is with in-hospital patients who are already here in hospital for some days or some weeks? Can we use this test also for them?
So it's a good question, right? I don't have a formal answer because they weren't included. When you think, or when you look, again, I don't want to extrapolate too much from suspected PE, but certainly we know that they have much higher D-dimer levels in general, right? Because of the reason why they're admitted is be it infection, be it cancer, like being surgery, being like all these are associated with higher D-dimer levels, right? So, but I don't know that there is any reason to suspect that if it was negative, that it would behave any differently, right? I wouldn't question. Actually, we don't have except for patients who are on anticoagulant treatment, we don't have many reasons many situations in whom the dimer would be less sensitive than in general, right? It's certainly less specific, but if it's someone that you, for whatever reason, you don't want to get an ultrasound, I think if it's negative, I would still be comfortable using it.
Yeah.
Yeah.
So for my side, one last question. So we also have a special population like pregnant women. So how do we work with them? Are the D-dimer tests also good for them, or did we need to forget that and to make an ultrasound at the first? Or what was your algorithm to work with them?
Yeah. So pregnant women, it's a bit of I would give a bit of the same answer. So pregnancy is associated with a higher D-dimer levels in general, and we know it goes up as well as pregnancy progresses, right? So, but when we looked at that in suspected PE patients again, so I don't know about suspected DVT, but in suspected PE patients, certainly a non-negligible proportion of them would have a negative D-dimer, at least first trimester, even the second trimester. And it's really only at the third trimester that you start seeing many less women with a negative D-dimer. They're much younger, right? So it's an easier situation kind of thing. Certainly there are other caveats with patients with pregnant women with suspected DVT, right? One of them is, in non-pregnant patients, we believe that, the DVT starts in the calf above a valve in a vein and then progress proximally, while we know that in pregnant patients, more often than not, it starts very high up, right, at the crossing of the iliac vein with the iliac artery, with the contralateral iliac artery, and that's where you can have some very proximal iliac DVTs that could be completely missed by the ultrasound. So if it's supposedly, it's not only about compression, right? You could do flow augmentation with respiration and see if you lose that modulation, but we know it's less of a sensitive. So my message here is, when you have a pregnant woman, even if the ultrasound is negative, but you have a strong clinical suspicion because they have an entirely swollen leg, or don't stop there, right? You need to either make sure that the radiologist is able to visualize all the way up to the vena cava, or sometimes get an MRI or a CTV to further investigate. But in terms of you could argue as well that we don't have a good pre-test probability model for DVT in pregnant women, right? So that could be another limitation to use a D-dimer test. But again, I don't have many reasons to suspect or to have concerns about sensitivity and ability exclusion.
Grégoire, I'm very thankful that you mentioned the ultrasound, that you really have to look specifically into the iliac veins and try to visualize the vena cava, because that's often missed, and that's something you have to do in pregnancy. It's again not rocket science. You have to do the probe and try to look in the iliac vein, look at as you said, on the flow pattern, and unfortunately, this is missed sometimes, and so that's very important.
I would love to add 2 technical questions and then maybe 1 or 2 general questions. From a technical point of view, you told us that the ultrasound has been done by technicians in Canada, so it's not the doctors who do the studies, it's technicians. And I'm aware you come from France, so how is it done in France? Because in Germany, it's always actually the doctor who has who is allowed to do the ultrasound.
In France as well, right? It would be an angiologist, or in Switzerland, obviously an angiologist as well. Yeah, in Canada, it's more often than not, it's an ultrasound technician, and then they would capture the image, with and without compression, capture some Doppler signal, but then it's interpreted by a radiologist. So it's quite a different, and by chance we had half and half, right? So again, that in terms of generalizability of the result, it looks like it works either way. But yes, that's certainly a big difference.
So when the patient comes in at, say, midnight, I guess the technician won't be in the ER. How do you proceed then in Canada? Are you waiting until the next morning? Or?
Yeah, so very often what happens is, certainly in smaller hospitals for sure, is that they just get a dose of anticoagulants, and actually that's how Dr. Wells here in Ottawa did his career about DVT diagnosis, is that they would be seen next morning in our clinic and then get the ultrasound here in the clinic.
There was an interesting Dutch study on that, and they were asking patients on the quality. They were asking, would you rather wait until 6 hours in the emergency room, or would you have an appointment on the next day? And everybody, or the majority, really agreed to come back in the next morning and have a shot of an anticoagulant, because if it's suspected DVT, they often don't have the highest priority in the emergency room.
Yes.
And so they are very unhappy, those patients. They wait until very late.
That's true.
Sometimes.
And every time, because even here in Ottawa, where we do have a technician at night, that technician is also doing, appendicitis and renal transplant and whatever it is, right, that comes in.
An ultrasound technician who takes care of everything which has to be ultrasound at night then. That's interesting.
At night, yes.
And the other technical question actually to the 2 of you, when you go for ultrasound, would you recommend us to do only the proximal leg or to go for the distal and proximal? Truly, I ask this because I'm aware that the late Dr. Carolin always told us not to go for distal leg ultrasound because nobody can do it. And if you got some results, whether or not you believe the results, nobody knows how to treat these people. So in your ADJUST study on the one hand side and in real life on the other hand side, what would you recommend us to do?
Yeah, so again, it's funny because that's how history is making the present, right? Is that historically, again, Dr. Carolin in Canada was very strong about what you said. But maybe the fact that ultrasound technicians are doing the ultrasound is an other historical reasons for that situation, right? I think it's different when in Europe people are entirely dedicated to that investigation, and also ultrasound techniques have improved, right? So whether Dr. Kieran's, had a systematic review, but that was back in, the late 90s or early 2000, showing a limited sensitivity, specificity of the ultrasound at the distal level. That has changed, right? So all in all, when you look at the studies, there are a couple of randomized trials comparing, repeated proximal ultrasound versus one single whole leg ultrasound. In terms of safety, both of them are good, right? So when you do a whole leg ultrasound and it's negative, you're good to go as well. When you do the repeated serial proximal, you're good to go as well. When you do the whole leg, you overdiagnose in a way, or you diagnose more patients with DVT because you will find some distal DVTs. So some people would say, well, that's good, right? Because then you find them, you treat them, and it's good for the patient. And others would reply, well, yes, but in the other arm where people only had a proximal vein image and they were not treated if they had no proximal DVT on the serial ultrasound, nothing happened to them, right? So the issue now is who are these patients who would have had a distal DVT that would not have progressed? Like it's hard to truly tease that out.
Mm. As I said, there are really cultural differences between the continents, really.
Yeah.
But as you pointed out, the ultrasound machines now are much better and they are getting cheaper as they were. And if you are trained for the complete compression ultrasound, it's really a fast technique. And it helps you to identify, of course, other reasons for the patient's complaints. That's one thing. Which is important, especially if you have like a muscle rupture or a Baker cyst that is ruptured, and you start an anticoagulant in those patients, you may really cause a huge hematoma or some bleeding issues. So that's an advantage. Of course, there is the story what to do with a distal DVT. But I think it is clear that there are some risk groups for where a distal DVT really means something important, especially cancer patients, for example. So it's good to discover that when it's only a distal DVT because the risk of progression is high. But for those muscle vein thrombosis, which you also detect, and it's very easy to find them, the data, of course, are not that good for the treatment. And so that would be another topic for study, for a large study, because the outcome is quite good for those muscle clots with and without anticoagulation.
And the patient doesn't have to come back after a week or so if you do the whole leg ultrasound at the first encounter.
Exactly. That's an important thing, limiting resources. That's one thing. And the patients are not very happy if they know they have a clot and they got no treatment. That's something which takes a lot of time to explain to the patient, and the informed consent on the treatment it's much more difficult than explaining a limited time course of an anticoagulation if there is no high risk for extension.
Yes, that's fair.
And then a more general question. So you did all these studies, and not only on the age-adjusted, you also tested some other novel approaches to diagnose or rule out deep vein thrombosis and pulmonary embolism. You wrote a fantastic review on that, and now we have a couple of different proportions how to proceed. So we have this age-adjusted, we do have the years criteria, we have the PERC, we have some other proposed. I just saw the recent AHA guidelines, which are rather complicated, trying to put all this into one chart. But for clinical practice, it looks actually too busy to come into real life. So how shall we proceed with these age-adjusted diagnosis criteria compared to the years criteria or some other criteria that have been proposed? Paget, I think, is one more.
Yeah, it's a good. Well, obviously, I might have a cognitive bias here, right? Because we're deeply involved with the age-adjusted. we did look in retrospect at the, what we call the pre-test probability adjusted cutoff, right? And so Dr. Kiran, that was his last study, actually, the 4D study, looking at the D-dimer level of 1,000 in patients with suspected DVT and a low well score and 500 above that. When you look at that in patients with suspected PE, admittedly looking back in retrospect in previous databases, you find that there are some failures of that in patients who had a D-dimer higher than their age-adjusted but lower than 1,000. If I go back to my figure, you see, and it's not a fully fair to them, but see, if I draw a line at 1,000 here, then I have quite a number of orange dots here, right? But when I'm saying it's not fair, it's because when in those studies, it was only the low, right? So admittedly here you have the intermediate and you have all the unlikely low patients that are there. So we would need to look back and see if you get rid of these, whether the 1,000 cutoff is okay or not. But when you look at that in the PE study, there were a few failures there. And I'm a bit concerned again that some of these studies using the 1,000 cutoff actually provided outcomes that were a pool of everybody from zero D-dimer to 1,000, meaning they didn't focus on the group of patients with a D-dimer higher than 500 but below 1,000, which would have been much more reassuring to me. So again, acknowledging my cognitive bias, well, again, I certainly, but I would be, for now, I'm a bit reluctant to go up to the 1,000. Maybe the exception is the years because it has been in use and there has been a bit more like external validation studies on that. But the 4D approach for suspected DVT, for example, it hasn't been reproduced so far. The PIGED approach, which was the same one for PE, the same when we looked at it, wasn't so good in a higher prevalence population. So maybe it's not so bad, but I would wait until at least we have another study to confirm. It's a bit different with the age-adjusted because we have so many, it's easy to look in retrospect, right? So a lot of people looked back in their databases at the age-adjusted cutoff. And all these patients did have imaging when they were doing the study. So, Italians did that. A lot of people published their cohort and showed that it was quite safe, actually.
My objections are somewhat that these years criteria are so largely based upon this question: do you consider venous thromboembolism as the most likely diagnosis or not? So there's a very strong subjective point in that.
Subjective.
Yeah, though I really like to thank both of you to share our webinar today. Thank you, Professor Le Gal. Thank you, Professor Bauersachs, for being here again by Marcus at home. And I'm sure that we will welcome you back in future because I think there will be a lot of new paper studies coming in the next year. So thank you for this time, and I hope we will see you again.
Thank you,
Thank
everyone.
you. Bye-bye.